Thank you everyone so much for joining us tonight. We've got a couple of great speakers that are going to be sharing with us their presentations that were highlighted from the ASMBS Weekend. So in case you missed it, we're gonna be able to kind of get a highlight, and this will also be recorded and available on YouTube, and you can see in the chat the link as well to the ASMBS website. So a couple of housekeeping rules. I know y'all are all muted, but please feel free to put any sort of questions or thoughts in the chat. We'll be monitoring that. One quick shameless plug. We are in renewal season for ASMBS membership. So please make sure to renew and tell your friends. Renewal does close January 1st. So we're definitely excited to have everyone here tonight. We'll go ahead and get started with our first speaker.
Fantastic. So I have the absolute pleasure of introducing Dr. Renee Hilton. Dr. Hilton is the section chief of minimally invasive surgery and assistant professor at the Medical College of Georgia at Augusta University Medical Center. She's the director of bariatric surgery as well as the Center of Obesity and Metabolism at Augusta University. And she is our chair of our Access to Care Committee and has done some fantastic work. And we're very much looking forward to hearing what she has to say about updates with access to care. Welcome, Renee.
Thank you very much, Christine. All right, I'm just going to go ahead and share my screen really quick. And let's see here. Hold on, I'm way too far forward. Let me go right back. All right, can you guys switch it out of presenter mode? Can you guys see me now? Are we all good? Okay, sorry guys, I'm not the most I'm way better at talking to politicians than giving slideshow presentations, I promise. Well, thank you again to this committee for having me on and for giving me an opportunity to give a talk that I'm going to call Access to Care ASMBS Weekend Cliff Notes. I have no disclosures. I do want to highlight not just my own talk, but I really wanted to do kind of a summary of the 3 different advocacy sessions that we had at Weekend. Usually at Weekend and at Week, there's like, you know, one advocacy session and it's in like a dark, like teeny tiny room in like the far abyss of the conference center. And there's like 8 people in the audience. And this year, Dr. Rogers has been amazing with her initiatives for promoting advocacy and reducing stigma. And we had 3 whole like huge sessions on advocacy and stigma and access to care. So the first one I got to do with one of my good friends, Dr. Judy Chen, who chairs our state chapter committee. And this was an advocacy summit that we did pre-conference. And we actually invited all of the stars from around the country and all the state chapter presidents to come and really have a summit where we focused on advocacy and strengthening our state chapters. And, you know, I put their pictures up here because all of these people gave amazing talks, and it included everything from talking about updates from the Access to Care Committee, which is my talk that I'm going to do in a bit, from talking about the changing landscapes of OMMs and, you know, what coverage might look like for these drugs in the future. And then Dr. Rogers gave, to me, a great talk highlighting her initiatives, but also really focusing on stigma and what our patients on a daily basis kind of have to face. In addition to that, the 2 other whole sessions on advocacy, one that really focused on stigma. And then we had another that I thought Kara Horn did a magnificent job doing. The session on the left was actually combined. It was surgeon and integrated health. And the one on the right was in our integrated health tract. And I was really jealous that I had a session at the same time because I was totally going to crash this IH session because I thought Kara put on a fabulous course. So I just wanted to give a shout out to all these people because I shamelessly ask them to give advocacy talk all the time, and they always say yes to me. So I really appreciate them. So to get to kind of the meat of the talk that I gave at ASMBS a couple of times was really just to update our chapter or our organization, if you will, on updates from our committee. And I wanted to kind of break these down into policy updates, new guidelines wins, talk about our state-directed or employee health benefit plans, utilization of benefits and media to promote awareness, our legislative efforts, and that includes TROA and our CMS issues, as well as local and regional. So at the beginning of every single Access to Care committee call, if you're on that call, you know that we have certain subcommittees or task forces, and they focus a lot on these things because all of them are so important to access. And then lastly, I cannot understate enough, if you're not a member of your state chapter, when you go to renew your membership, I like how I got that in there, Emily, renew your membership, but also check your state chapter button, because I think there are a lot of benefits in your state chapter level, and they certainly rely on grassroots movements, local movements for advocacy. And then, of course, always our ultimate goal in Access to Care is to advance advocacy and get our patients treatment. This map I love because for the first time, I think certainly in the history since I took over as chair of Access, we have a star for every single state in the entire country for surgeons. And what we still do not have, and why I'm glad that we're showing it here on this call, is I do not have IH stars in every single state yet. And it is my mission before I finish my reign of terror in June this year. I really want IH stars from every single state. So if you're interested and you're watching this webinar and you want to learn about advocacy, reach out to me or Leslie Vinson and let us, get you engaged. So I also wanted to talk about some changes we've made this year. We did some major overhauls to the Access to Care toolkits. I feel like I go to these toolkits all the time. Like anytime I'm looking at like how to code, for SAIDI or something that I may not be that familiar with, or, how to fight an insurance company, like who's had success with peer-to-peers and appeals. I go to these toolkits, and we did a major overhaul in October. Please go, and I've included the website at the bottom of this slide. Go to that website, take a look at our new Access to Care toolkit. The big feature that we got our board to approve in September, just in time to really showcase them at ASMBS Weekend, we have 2 industry-sponsored dashboards, and that's really the meat of this talk tonight, because what I'm going to show you is I'm going to kind of give you a tour of these, and there's 2 different ones. They are both industry-sponsored. ASMBS did not do them, but our board has approved them. One is sponsored by Medtronic, and one is sponsored by J&J. I'm going to get out of here now and go online. Can you guys still see my screen okay? I'm getting thumbs up. All right. So just to show you where this is, again, you go log in with your member user ID. You're in ASMBS. And you go to the Access to Care Toolkit, which is under Resources. When you get there, just scroll down, and front and center on this page is where you're going to find these dashboards. I highly recommend you look at these user guides before you just jump in. But I'm basically going to be your user guide tonight. So I'm going to click on the first one, and every time you click on one of these, you're going to get this disclaimer box that pops up. This basically just says if you get, maybe a little outdated insurance information, you're not going to sue the ASMBS or Medtronic, okay? Like you're using this understanding that it may not be a perfect tool, but I got to tell you guys, in all the years that I've been doing advocacy and access, these 2 dashboards are just lights out amazing. So what you see here is this is the Medtronic dashboard. First thing I love to highlight is, look at this number. More than 90% of this country has access to metabolic and bariatric surgery if they have a policy. So I feel like, sometimes we feel like we're losing, right, with access, and we're not. We're winning. Like we're doing better than we've ever done before. And I feel like things are just getting better. So I will point out this box up here in the top. Once you get familiar with this dashboard and you like it and you want to use it more, you can click here and subscribe. You can actually receive email notifications about policy changes in your state. So for me, if I get a policy change in the state of Georgia, I want to know, and I want to know real time. So you can actually click here and subscribe to emails. There's also another little fast button down here. See this? It says click to see changes since your last review. If you log in through ASMBS, it tracks when you're using this. So if I come in here and say click to see changes since last review, it'll take me to a page where it shows me all the updated policies since I last used this tool. So now to get down to the nitty gritty, I'm in Georgia. So I'm going to click right here on the state of Georgia. And so now what that has done is it has broken this down by payer. All of these payers have to have at least 50,000 people enrolled in the policy to be included. But I'm going to click on Anthem because Blue Cross Blue Shield's gotten a lot of I've got a lot of press coverage in the past couple of days for being jerks. So we'll look at their policy. There's several ways that you could view this and look at it. I really like this coverage summary. So if you go down here, you see here we've got, Aetna. The policy titles obesity surgery. It's going to give you a highlight of what procedures they cover. So here you can see they cover SADI, they cover revision of primary surgery. It's also going to tell you specifically covered populations. So they have on here, what adolescents they cover. It'll also say on here in additional comments if there are specific criteria for those adolescents. So you can see here they do have some kind of archaic things like, have completed bone growth. We know that that's not accurate anymore, but again, it's nice to know this so you know kind of what to include in your documentation. And then the prerequisite box I find very important for my nurse navigators, for my coordinators, for my dietitians. Tells them exactly what this insurance policy wants to see when we submit that packet. So again, I love this. The last feature that I absolutely love is if I click on Aetna, it takes me directly to their page. And so my people that want to review these policies, they don't have to look for it. They don't have to search through Aetna's page and wade through all the garbage. They click on this and it takes them straight to the policy. And it has literally, here's the whole policy, guys. I cannot say enough about how amazing these dashboards are. I'm going to go ahead and close out of this one. So that was just one example of, how you can use this. I'm going to go back to the toolkit. Now I'm going to open the second dashboard because they are slightly different. This is, just kind of pick whichever one you like to use both of them. Play around with them and see which one, is your favorite. But you can automatically see right from the start, they're pretty similar, right? Like they've got kind of the same even look to them. This one is defaulting to Aetna. So I'm going to go back and I'm going to, pick the same state. I'm going to pick Georgia again so that we can see, here we have the policy. If you want the policy link, this time it's up here under policy link. When you come down here, this is what's different on the J&J one that I really like is they actually tell you if GLP-1s are covered for a lot of these policies, which I think is really cool. And they have a restrictive scoring box. Joe Northrup was really great and Scott Woven, they put this together. And so you can see for Aetna, it's actually low. So when we give these restrictive ratings, low is 0 to 3, medium is 4 to 7, high is 8 to 11. And when you look at the criteria for the scoring, it's things like long-term BMI. So for a policy that says you have to have documented 5-year history of obesity, like you guys have seen these policies, right? Like who can go back 5 years through medical records and prove that someone's had obesity at every visit? That's going to get a really high score. You don't want a high score. The higher your score, the more restrictive your policy. The goal with this is that if you're going to go talk to a medical director, they don't like to be last. They don't like to look inferior to their peers. And if you're showing them, look, you have a very restrictive policy compared to other insurance. I do think that these restrictive scores might help. Again, it covers things like repeat surgery in a lifetime, repeat surgery coverage. Yes, they do have it. And so that's another thing that flags a really high score. If they've got a one and done, meaning once you have one surgery, you can never have another. We consider that to be one of the most restrictive policies that's placed on our operation because we all know that obesity is a chronic disease. Offering one operation is incredibly restrictive. So there you have it for the dashboards. So I am going to go back now to my PowerPoint. I think I did that okay. All right, now we're back. You can see it. We good, guys? All right, awesome. So again, I just want to point out, we've made all these advancements and we are winning. We have more than 90% of the country is covered. But when we look at specific things like our new guidelines, and our SADI, SADI coverage. To date, we have more than 123 million lives that are already covered by the new guidelines that were just put out in 2022. We literally have 48.7 million lives being covered for SADI. I mean, that is real progress since 2022 that I'm incredibly proud of the committee for doing, because that's real grassroots, movements. And so I always like to end is how can you make an impact? How can you, I hope that you've seen some of this, you're inspired and you're like, wow, like I want to contribute to some of these numbers. Join our committee. So my three co-chairs are Dr. Gotchison, Dr. Kajese, and Dr. Tischler. Our EC liaison is Joe Northrup. And again, we would love to have you on board. Please encourage, not just surgeons. I want IH members. I want RDs. I want coordinators. I want psychologists. I want people that don't think the same way, because while I'm going to advocate fiercely for surgery at the turn of the corner, I mean, the amount of, policies that do not cover mental health or do not cover, behavioral health, treatment of obesity or medications. We want to advocate for all things because a rising tide lifts all boats. So last but not least, I'm going to give a huge thank you to Leslie Vinson, the heart and soul of Access to Care. Your work and commitment to our committee and our patients is so appreciated. My email's here. If you guys will reach out to me, I'm happy to have you, have a talk with me and Leslie and hopefully get you on the committee. So thank you.
Fantastic. Thank you so much, Renee. I have such a passion for this, and I have to be honest, I have been feeling a little bit like we weren't winning for a little while. So I'm really, really happy to see this, and it actually really does inspire me to keep pushing forward. Do you want to do questions now, Emily, or do we want to do them at the end?
So typically we'll do it at the end, but Renee, I know you're on call. Do you want to just field some questions real quick?
No, go ahead and let go ahead and let Aura go. I'm good.
Okay, perfect. So we will move on to Aura. Thank you so much for being here with us tonight. Aura Petcu is an assistant professor at Oregon Health and Science University in Portland, Oregon. She is a board certified nurse practitioner with 10 years of bariatric surgery and obesity medicine experience. Currently, she is a member at large of the ASMBS-IH committee, executive council, an active member of the ASMBS-APP committee. She is passionate about her field because she feels it promotes overall health, quality of life, self-care, and increased knowledge of the chronic disease of obesity. She is active in national, regional, and local obesity and bariatric surgery committees, enjoys advocating for obesity education and reduction of weight bias, and is always learning to keep her skills up to date. Thank you so much.
Awesome. Thank you guys for having me. So let me share my screen here. Okay. Can you guys see it okay now? Okay, perfect. So we're going to be talking about incorporating anti-obesity medications in the preoperative metabolic and bariatric surgery patient. So this kind of is just one of the many talks that we had at the weekend that was talking about AOMs and how we can incorporate them into our practice. My specific talk was speaking of the preoperative way, but we did have some post-op management and just different BMI levels that we were also talking about. So do go back and look at those as well. They're really great talks. So this is just a snippet of what was there. So let's chat a little bit about this. So objectives to this talk are why should we be considering these medications in pre-op management? Who should be getting these medications? What medications should be given? How should we give them? And what kind of future research is needed in this field? Now, to understand the why, I often look at the guidelines. And so ASMBS had a guideline position statement that was listed in 2022. And the 4 reasons that they came up with for why we should consider them is for reduction of perioperative risk, to increase the amount of patients that are safely getting to surgery, to reduce the comorbidities after surgery and for additional weight loss that can be happening for our high BMI patients. I am going to move, there we go. Okay. Who should we be doing this on? Honestly, I think the answer should be pretty much any of our patients really could benefit from some sort of pre-op weight loss medication. But if we really want to find out, identify certain places that we can do it, it's going to be in our patients that have the high BMIs greater than 50. I think they're a really easy target that we can say, okay, let's get you into a safer BMI so that surgery can be done safely as well. Those patients who cannot have surgery for whatever reason, for non-surgical candidates, they could at least get, a little bit of weight loss before that. Maybe then we can get them to a safe surgery as well. And then those patients who have high surgical reasons, if they've had previous surgeries, if they're high risk candidates from a medical standpoint, they're also going to be a good place to start. But really what I want to take home with this is I think pretty much all of our patients can benefit from some sort of preoperative AOM. Now, how do we do this? There's lots of different ways that we've thought about how do we manage the disease of obesity. And I think our old school thought process was kind of going from low risk to high risk. So if you look here on the left-hand side, it's kind of looking at that graph of efficacy versus risk. So the idea would be that we start at lowest risk of lifestyle intervention, moving all the way through medications to endoscopic procedures and surgical procedures. But I think, though that may not be a wrong way of doing it, there are probably better ways that we can look at it. So another model we can consider is looking at the chronic disease model of care. So we have the patient in the middle, and we have all the different disciplines around it that can be working on managing from multiple locations. So we have the surgeons, we have the nurse practitioner that can do AOM management. We have our dietitians, our psychologists, our exercise therapists, basically anyone that can bring in any sort of intervention that helps the patient. This is all going to bring their risk factor down for both their disease management and to get them to safely to surgery. So that's two ways that we can look at it. But one of the most newer novel ways that we've been thinking about it recently is looking at the treatment of cancer and how we manage cancer patients and comparing that to how could we use that for the management of our obesity patients as well. So when we think of cancer patients, we think of a neoadjuvant therapy and adjuvant therapies. In the cancer world, the idea is to reduce the size of the tumor with neoadjuvant, reduce that size, the tumor burden, so they can safely get to surgery. And then with an adjuvant is to continue reducing that, recurrence or just to reduce it more. So if we look at that in the aspect of the lens of obesity management, same idea. Neoadjuvant would be optimization phase. So how do we get you optimized to get your condition best controlled or to even get you to surgery? So in our world for optimization, I really consider that are places like behavioral health therapy, nutrition and exercise education, and then in this talk, especially AOMs, really using those medications to optimize them, to get their comorbidities as best control as they can, to get their weight as low as they can so they can really be safe for surgery. And then in the adjuvant treatment phase for obesity, you can think of it more as a maintenance phase or a prevention phase, basically prevention of weight recurrence and ongoing weight management support. So thinking of it as, okay, we've had surgery, we've done the surgical intervention, but how do we manage this continuously? As we know, this is going to be a chronic disease and we need to keep going with it. So using AOMs is going to really help prevent any weight recurrence, can help with additional weight management if they're wanting to lose more. And then using the other supports, such as our behavioral health and support groups is also a big one with this adjuvant phase as well. So again, using these two ideas of treating patients with neoadjuvant and adjuvant, I think is a really good way to think about it as a long-term solution for a chronic disease process. So what's next? So we've identified our patients. We say, okay, this is the patient we should be doing it on. How do we do it? Well, this is where it gets a little complicated. There are many factors that we need to think about when we're picking medications, when we're picking how should we do it. But the things on this slide are kind of the big ones. And I hate to say it to start with it, but insurance coverage is going to be one of the biggest ones because a lot of our plans out there do not have coverage for anti-obesity medications. So we do have to consider if our patients have the financial ability to pay for these medications and can they do it for a long-term also, because we know that we do need to do it for more of a long-term solution rather than a short-term. So insurance coverage is an important aspect, but also thinking about within an insurance world, if patients have comorbidities like diabetes, or if they've had a previous stroke or MI, we can use these previous comorbidities to to gain coverage for medications. For example, Wegovy has recently been approved for patients who've had previous strokes or MIs. So using their previous history can also help us gain that coverage in certain populations. Now, if insurance is not is not covering those medications, cash pay options are there. They're very expensive, as we all know, but I do think it's important for us to have those conversations with the patients so they're aware of their options. You know, we may not think that people are going to want to pay $1,500 cash pay for the medications, but some they want to get to surgery and they know that that's what they want, and so sometimes they'll make exceptions for to get there. So I think it's important for us to bring it up at least. And then how do we pick the medication for patients? Well, there's lots of ways to go about it, but I think what's most important is honestly talking to them about their symptoms, asking them where is their hunger? Are they having head hunger? Are they thinking about food? Is it the food noise that's bringing them to eat? Do they have cravings? Are they night eating? Is it stress, emotional eating? Or are they eating and then feeling like they're getting hungry very soon thereafter? All of these different symptoms are different pathways in the body on how they're created to have hunger sensations. And a lot of the medications will actually be driven by these different signs and symptoms. So you can pick the medication that fits best with their symptom just by talking to them. So I think that's really important and a big sticking point when you're picking a medication for patients. And then the other aspect is to really remember that it's not a one size fit all. So one medication may not fit for everybody. You know, we all have this love for these GLP-1s, and whereas I love them as well, they're not necessarily meant for everybody. So we have to remember there's other medications out there, and also we can use them in combination. So just because they're on one medication doesn't mean they can't need a second. It's just like treating any other chronic disease. We use as many as we need to get it best controlled. And this is a paper that I actually it's big in my practice for me. When I first really got into working in obesity medicine, in addition to bariatrics, this really helped me kind of not standardize, but just give me a starting point of how do I prescribe these medications to patients? How do I know where to start? So this is a paper that was done by Acosta in 2021, and it really just went into describing the 4 phenotypes of hunger. And so he basically described the hungry brain, the hungry gut, emotional hunger, and the slow burn. And there are different ways that this is manifested in the body, and then different medications that can be used to manage these different hunger sensations. So for example, with the hungry brain, it's the patient that feels that they're constantly hungry, they're thinking about food, they're craving food. So phentermine topiramate can be an option for that. And often I will also use Vyvanse for this one because sometimes patients will have some binge eating disorder, and sometimes that can be associated with just kind of thinking of food constantly, as well as ADHD. Patients who have ADHD will also have some sort of binge eating sometimes. And so having that FDA approval for Vyvanse for ADHD and for binge eating is a great combination for that one. The hungry gut. I really do think about this for patients who feel like, okay, I just ate, I know I just had a high protein meal, and an hour later I'm hungry again. That's the patient that I consider for the GLP-1 group, because what that will do is it slows down that transit time with the GLP-1. And so it helps them have that satiety that they're not getting normally. With the emotional hunger, I really think about patients who have an association with maybe having a reward with food, or they're stressed and they eat. So that emotional connection with food and their eating habits. So and then also if anyone's had a previous history of any kind of addiction, I also think of patients for this emotional hunger world, because the medications that we can use are bupropion and naltrexone. And naltrexone on its own can help with addiction purposes. So in our world, it can kind of help reduce that the drive, the instinct, the impulsivity that can kind of come with that emotional drive of hunger. And I'll also often use the topiramate for that. So those are the kind of the options that you have in that world. And then the slow burn is the one that I feel like we really consider the patients who have lack of mobility, patients who are mobile or maybe have back pain that can't do a lot of activity. I consider them having, lower energy expenditure. So by adding, let's say, phentermine or another type of stimulant, you could potentially increase their metabolic rate ever so slightly, where maybe it's going to help them a little bit. So though this is not, an exact way to practice medicine, I do think it's a good guide for anyone that's new to the field and starting to figure out where do I incorporate and how. So definitely something to look up. He's written 2 different papers on this, so definitely look it up if you're interested in more. And then medications in itself, there are many ones that we have out there. I'd say the most common things I use in my practice, and I think a lot of our colleagues do as well, are going to be the GLP-1s and the GIPs. So we have the Wegovy, the Zepbound that's used for obesity, and we have the Ozempic and Mounjaro used for diabetes, but we know that it also promotes weight loss, so it can be used for both. And then the Wegovy now with the cardiac indication with the previous history of MI and stroke. The stimulant family, there's the Qsymia. I personally don't use Qsymia a lot because it's very expensive and my patient population can't afford it often, but I will separate the two and I'll use phentermine solo. And then sometimes I'll also use topiramate off label for weight loss as well. There's the Vyvanse that we were talking about earlier. Then there's the topiramate and then zonisamide you can use if the topiramate is not tolerated well. Or the Contrave, which is the bupropion and the naltrexone that you can use as separate agents as well. Orlistat is still FDA approved for weight loss, so you can use it. I will say personally, I don't use it much in my practice. Not many people tolerate it, but it is still out there. And then metformin can be used off-label as well. So definitely something that you can consider. There are more out there, but these are the big ones. So now just going into a few papers to show the importance of how they can promote weight loss before surgery. So looking at GLP-1s, this was a study that was done in 2023, and it was looking at patients who had BMIs greater than 50. There were 31 patients in this cohort, and they had 58% of them were put on a GLP-1 preoperatively. And what they saw was that the treatment group had a 5.5 BMI point reduction versus the control of a 2.9 reduction. So though it's not a huge point reduction, it's still something, and it definitely still helps patients have a lower risk for getting to surgery. So it's just going to show that any kind of reduction is going to be better than that, especially in those patients that have the higher BMIs. Now, looking at phentermine topiramate, this was a study that was done by Cunningham. This was also done in 2023, and their study looked at both neoadjuvant and adjuvant use of phentermine, 37.5 milligrams daily, and topiramate, either used preoperatively or in an early postoperative period. So in this talk, we're talking about pre-op weight loss. So we're looking at group 1 in this chart here. And what you're going to see is the patients who were started on medications pre-operatively lost a lot more weight than they did if they were started post-operatively. So group 2 was started at 1 year and group 3 was starting at 2 years post-operatively. They had lower reductions in their weight loss than the patients who were pre-operatively. So it goes to show that it's going to help us both for the patients to lose weight, but then they're also going to lose more weight as if with surgery than if they hadn't done it initially to begin with. So another good reason to bring it in ahead of time. This is yet another study that was done by Art et al. This was done back in 2019, so a little bit of an older study, but this study actually looked at sleeve gastrectomy versus sleeve gastrectomy with phentermine and topiramate. And so what they found in this one was that the phentermine topiramate group lost over 2 times more weight than in the preoperative period than the controls. So we're looking at a 28.1 kilogram versus 12.3 kilograms. So pretty significant there. It was almost double. And then at 2 years, there was an excess weight loss percentage of 18.2% that favored the phentermine topiramate group. So again, more weight loss even long term. And then in the patients with super obesity, a higher portion of them that were treated with the phentermine topiramate and the sleeve had achieved a BMI less than 40 at 2 years of treatment. So that's really important as well because, sometimes it's hard for us to get our patients that have the high BMIs to that BMI under 40. So it's great that we have that option of using medication in adjunct with it. This is just a case report that I found during my research on this topic, and I thought it was really interesting. It's a very small case study. There's only 3 patients involved in it, but the reason why I bring it up is that it's using topiramate and metformin, and those aren't usually the most you don't think about them as the ones that affect weight as much as all the other GLPs and other things we've talked about. But in this case report, they looked at 3 patients, one who received topiramate at 25 to 50 milligrams daily for 12 weeks. This patient had a total weight loss of about 8.2% preoperatively. A second one had metformin at 500 and topiramate between 25 and 50 daily for 6 months before surgery and had a total weight loss of of 15% preoperatively. And the third patient received topiramate at 25 to 75 and had total weight loss of 36% at 22 months and no longer wanted bariatric surgery at the time of this publishing. So though these are, I'm sure, they're not the most common results that we see, the reason why I like to bring this up is that we can use these medications and they can still promote weight loss, and they're very cost effective. Though we would love everybody to be on the most effective medication we have out there, sometimes that's not the choices that we have available. So knowing that these medications that are cost effective can still be actually effective in weight loss is important, so you keep it in your arsenal of tools. Now, putting it into practice. So for me, this is kind of my personal way of doing this. Who do I put on a medication? I really always try anyone that has a BMI greater than 50 who's preoperative with us, I'll try to get them on some sort of medication. If there's somebody who's struggling with their pre-op weight loss, I also want to consider it with them just to give them an extra assistance and boost to know that they know that we're on their side and helping them in whatever way we have. I always consider, is there a reason why we can't do an AOM? And if there isn't a reason, then why not? Any medication is going to be better than none. I think the most important part of when you institute any medication for patients is we really have to have follow-up. You can't put them on it and just say, okay, good luck with this, and we'll see you on the other side. You really have to have frequent follow-up. So I often see patients the first month, every month for the first 3 months in a row to make sure they're doing well with it, seeing that is it effective? Do they have any side effects? Do we need to add other medications if it's not quite as effective as it needs to be? And the other big part of it is you really have to think about how much time do you have to surgery? Because if somebody, let's say they have coverage for a GLP-1, you put them on it, but then they only have 2 months to get to surgery, that GLP-1's not even going to be at therapeutic level by the time they get there. And then you're going to be taking it off. And so you may not be getting the effect of the medication that it would be normally had if it was a longer time to surgery. So you really do have to think about these things in a pre-op patient. But still, you can add a different medication, maybe not a GLP-1 if they only have 2 months to go. But good to think about timing to surgery. Now, what do I do with a patient? What medications do I do as a practitioner? Most of the time, if a patient has GLP-1 coverage, I will go there. I will use their comorbidities if I can with the diabetes or the stroke or MI, especially if they're having postprandial hunger, I'll definitely go to the GLP-1s. Ideally, I'll pick a Zepbound or a Mounjaro as a first-line treatment if possible, simply because I've noticed less side effect profile with patients, and then Wegovy or Ozempic. The other thing I do is go low and slow. So if they are doing well on a low effective dose, we don't necessarily increase unless they really need to. If they're having stalls with weight loss or if they're not having enough appetite suppression, then we'll increase as we need to, of course. If they don't have GLP-1 coverage, then I'll often go to phentermine and or topiramate as a combination. Different dosings depending on each person. One of the beauties, I think, with using phentermine is you can do different dosings. Start at 8 milligrams, 15 milligrams. You can increase to 30 or 37.5 as needed, or a combination of it. Often I'll have people who start at 15 milligrams daily, and then we'll go to twice daily at 15. So we do 15 in the morning and 15 in the afternoon, just because sometimes they notice that their hunger sensation's coming back in that late afternoon. So having that second day dosage helps with that to bridge through the rest of the afternoon for people. That doesn't always work for people if they have insomnia. So we have to make sure we look at that as well. But there's definitely different ways you can do your phentermine dosing, which is why I use it very frequently. And same thing with topiramate. I start low and slow with this one as well, 12 milligrams nightly. This is one I find that patients either tolerate really well or they don't. And if they do, then we can keep increasing the dose. I do find that the combination of phentermine and topiramate is superior than the phentermine alone, but that's anecdotal evidence from me from what I've worked with. And then the Vyvanse I'll use for patients who have a binge eating disorder or if phentermine is not tolerated. Sometimes patients tolerate the Vyvanse a little bit better than the phentermine. So that's another option. And then the bupropion and naltrexone or Contrave, we can use on patients who have the emotional eating. So often I'll start at a low dose of the naltrexone. That tends to be the one that has the most side effect profile. Most people will notice nausea if they're not going to tolerate it. But if they tolerate it well, it's pretty effective for people who have that impulse control. And then the bupropion is really pretty well tolerated as well. I usually start at 150 milligrams daily and it can increase to a max of 300 daily. So that's just kind of how I do it. And then looking at here, this is just another example of how I do it. If I start someone on a GLP-1 and they're still having hunger, what do I add next? I'll usually add phentermine. If they're noticing more emotional eating, even though they're on the GLP-1, then I'll add the naltrexone bupropion. If they have cravings or night eating, especially, we'll add the topiramate. And then, of course, if they have some binge eating or ADHD, the Vyvanse. If the patients don't have coverage, usually my go-to, if they have no contraindications, we're going to be the phentermine topiramate. And then if the stimulants are contraindicated and still no GLP coverage, then we'll do the topiramate or the bupropion and naltrexone. And then, of course, if they are not achieving their weight loss goals or they're not having good control, make sure you're using a combination of therapy and medication. We have a bunch out there. We just need to use them. And, things to think about when you're using AOMs and preoperative considerations, make sure you're thinking about the side effect profile of the medications. So for example, with phentermine, a lot of times anesthesiology is worried about hypertension with that. So they'll want to make sure we stop that ahead of time. So you'll definitely want to talk with your institution and figure out timing for stopping that. Not everybody does it, but I think most do. Same thing with GLP-1s. Because of the slow motility, there's going to be that risk of aspiration. And so you'll want to talk with your anesthesiology colleagues to figure out timing of stopping that as well. And cost and access for these medications going to be big. The cost is huge if people are paying out of pocket for a lot of these medications, and access to the medications, not just from an ability of paying for it, but also getting it consistently. There's been a lot of just access issues where there's not supply in certain areas. And so people will get put on a medication and not be able to get it consistently. Well, then that's not doing us any favors because they're not able to get it consistently and we can't get that good therapeutic dosing of it. So definitely consider all these things when you're putting people on them. And then just future thoughts, I think by adding pharmacological therapy to surgical patients, it's going to improve outcomes beyond what's possible with surgery alone. So it's definitely something we definitely need to incorporate in our practice. And we need to start looking at these for like using AOMs for second stage procedures. Do we do second stage procedures or do we not? Do we use AOM? So using them and doing a little bit more research on that. And in general, there needs to be more studies done on these medications in the pre-op period. There really isn't that many of them out there now. There's a lot more in the post-op world, but so we need to do a lot more, especially now that we're getting more and more of these medications coming out on the market. Those are my references.
Much. Again, I want to encourage everyone, please drop your comments and questions in the chat. I have questions already. I do want to ask about what percentage of your patients preoperatively do you find are able to do the anti-obesity medications?
Oh, that's a hard question. I think a lot of them can, because we can use like the medications that are a little more affordable, like the topiramate, the phentermine. I think what ends up happening is they get a little discouraged because they're hoping for that massive weight loss that they hear about with all the injectables. So I think that that tends to be why people come off of them sooner than I'd like them to. But I do think I try at least 50% of them to get on them.
That's great. Do you find that any patients have kind of fallen out of the queue for surgery if they're on the GLP-1s and seeing a lot of success?
I don't.
Or delayed. Okay, good.
I don't, because I think people are realizing, so when I do a consultation, I talk about all the potentials, right? I talk about the medications and what they can lose, and then the surgery and what they can lose. And then we talk about the chronic disease of obesity and that even after surgery, you may still need some additional support. And so when you lay it out that way and you explain it that way, they understand that, the medication may not be the only solution. The surgery may not be the only solution. And so they start to understand that it needs to be well-rounded. And so I think it depends on how you present it to patients too.
Definitely. Renee, for the toolkit, thank you so much for going through that first off. I think a lot of times we forget that those are there. So it's helpful to have a walkthrough. Now those are more of the broad policies, correct? We're still going to encounter those employer-specific exemptions and specifications, right?
Definitely. So these were again, these are the bulk of the country, but it has to they have to have at least, I think it's 50,000 employees in the company. So you're like local mom and pop store that, employs 10 people. That's not going to be on the dashboard. But for the for the majority of your patients, it's going to be like the big guys. And the other thing that is nice about one of the dashboards is it actually just includes the 10 most populous policies in the state. So if you live in a state like Wyoming and there's only, so many coverages, or, there may be one on there that only has, 10,000 employees, because they wanted to make sure each state had at least like the top 10. But again, the thing that I love about that toolkit, or the dashboard specifically, is it's great for everyone in your group. If you're a member, you can access it through the web page. If you're not, there are direct links that you can actually give people that are not members within ASMBS that can go and use them as well. Even for the committees, I think there's broader use of these. For example, I think the one and dones, I think that's probably one of the most restricted policies that we have in place in some insurances. So I'm actually having the industry experts that have built these dashboards, they're getting me a list of every policy in the entire country that has a one and done. We've never been able to do that before. We've relied on, like, Christine emailing me on Monday morning when she gets a denial, that whatever insurance in her state has a one and done. And I've tried to make like an Excel list of it. So I think these dashboards are going to make advocacy a whole lot easier for some people.
Absolutely. And kind of that was a question I had too. How have you been able to implement this into your practice, and what kind of changes have you seen as far as efficiency goes?
Yeah, I think that the biggest way I've already implemented it is I check it pretty frequently, and I get these updates. One example in California is Blue Cross Blue Shield. Pearl Ma was actually playing with the dashboard at weekend as I had just given this talk, and then was like, "Oh my God, Blue Shield changed their policy again." Blue Shield in California, they give me whiplash because they change their policy so frequently, and it's like the best policy on earth and then the worst policy on earth. It's 12-month restrictions, and now there's like no restriction. But that was important for them to know real time, because they just did away with their 6-month pre-op requirement. So Pearl actually shared with me last night that they were able to go ahead and call patients that were ready, that were just in that 6-month arbitrary holding pattern, bring them in and get them to surgery. So that's one example. The other example in Georgia is I've been, fighting with one of our Medicaid groups for a long time. And I finally got a friend in the medical director office who said, if you'll just send me like the new guidelines and information, I'm really going to try to get them to change this policy. And they did. They did away with their 6-month pre-op. So I have Medicaid patients that I can get to surgery in a month if they're ready, or, 2 months or 3 months. So I think if I did not have the constant updates, I mean, we get busy. We forget to look, right? Like, it's really nice for me to just be able to click on an email and get those updates. And they happen pretty frequently. So stay tuned. We are developing a advocacy 101 course, if you will, that people will be able to sign up for, both surgeons, IH members, everybody. And Chris Gallagher and myself are doing it. And it's basically meant to take someone who's never done advocacy work. You do this course and you walk out and know how to go get started. It can be very intimidating to go on the Hill for the first time, but it doesn't have to be. But just like you wouldn't walk into the OR and do an operation without mentorship, I think advocacy is the same.
That's great. We do have a question in the chat. How do you manage, actually, let me go back, sorry. When starting off incorporating anti-obesity medications into a comprehensive clinic, are there any suggestions for how to go about setting up a pre-authorization and cost estimate process for each patient based off of their insurance? There seems to be a huge barrier to even taking those first steps.
Yes, I would agree. It is a very big barrier. I wish I had a good answer for that. I will say there is a tool I know on the Wegovy website that patients could go in and check their coverage to see if they have coverage. I don't know how accurate it is, but I know it exists. So that's something that I often tell patients because I think that there is a part where they need to take some onus on it too to find out if they have coverage. So I try for any of the patients that are coming to see me for weight management to have them call their insurance company ahead of time. And we send them a list of what medications to ask them for and what diagnosis, because it can get very confusing. But I'll try to have them do that. That doesn't always happen, let's be real. And so often when they come in, we'll talk about, I don't know for sure if you're going to have coverage or not. And a lot of times there's also confusion on are they going to get coverage for Ozempic versus Wegovy? Do they have diabetes? Do they not? So then there's a lot of discussion in that regard. So my biggest suggestion is, if at all possible, having the patients look at their insurance ahead of time. That is the best. If that's not the case, then you just kind of have to explain to them the differences between the meds, how they're usually approved, and go over the idea that it may not be covered. And if it's not covered, that is okay. There are going to be other medications that you can do cash pay for. That's why we have to always remember, at least in my mind, GLPs are wonderful, but there are many, many other medications that we still have available and that work that we can use.
Definitely. And I know that authorization process ends up being a full-time job. You need an entire FTE for that. I don't know what kind of setting you're in. I don't know what setting you're in, but I know a couple of things within my health system that we were able to find out. We've got our own specialty pharmacy, and they actually have staff that does that insurance authorization. And so our physicians that were prescribing it, we had them route to our specialty clinic, and they were able to kind of farm out that component.
App. This was Dr. Jane that was asking. So this is an app that I got from, I don't even know if you can see it on here, but it's an app called, oh, that's really tough. It's actually just called Access. Coverage. So if you go on the App Store and you just type in coverage, this is what it looks like. It's in that bottom. Let's see if you guys can see it. Bottom right corner. I know. I'm gonna have to take off my thing, I think. Bottom right corner.
Yeah.
That's what it looks like. And it will give you, it kind of like the dashboard does for surgery. It'll give you real-time updates in your state about which insurance companies cover which medications. Yeah. So I found it to be very, very helpful. It doesn't help us with the prior authorization process, but it certainly does create a little bit of an easier time when talking to patients about it. But yeah, I think making it realistic for them and helping them realize they may or may not get this med is an important thing to do. Yeah.
I'm gonna go out on a limb and say that I don't think you need to pre-authorize or the meds before they come in for a comprehensive clinic. And the reason I'm saying that is because there's more to treating obesity than just surgery and just medications. If they know before they ever walk in the door that they don't have anything covered in terms of GLP-1s, they may not even be open-minded, as Aura said, to like our other medications that most people can't afford or have coverage. But also, I mean, I'm sorry, but the person with a BMI of 65 does not need to just be put straight on a GLP-1 without a discussion about metabolic surgery. So I like to get them in the door. I like to have a conversation about obesity and what it means and what the treatment options are. And then we go from there. Let's write the prescriptions. Let's see what we can get covered for you. I think that the way that we need to be thinking about treating these patients is a more holistic approach and not just verifying benefits for one arm of treatment.
Yeah, I think I do the same thing. I just write for it, and then I say I'm sorry to my MAs because I know they do tons of these every single day, and I'm like, please just try to get it covered.
Yeah. I mean, and I think that's to your point, whenever you are with the patient and y'all have decided on an action plan, okay, well, now what do we do from an authorization perspective?
Yeah.
And we also check hemoglobin A1Cs, because if you check the hemoglobin A1C in clinic, they may not get Zepbound, but they may get Mounjaro. So I think there's a lot of benefit to just getting these people in the door and making them understand that what they have is a disease that needs to be treated in, multiple different fashions. And again, I think that we can reduce some of the stigma and the struggle that they're facing on a day-to-day just by bringing them into our clinics and offering them some support.
Agree. There was a second part to that question. Varun was asking, when starting off AOMs, oh, sorry, it was the next one. To manage pre-existing diabetes medications when adding GLPs, are those GLPs better managed by their endocrinologists? Alternative, if we just add on GLPs, is there specific monitoring recommended? And I was going to ask too about what you do for, do you get EKGs? Do you get basic labs on all these patients? So I think that's probably part of the what he's asking as well.
I mean, in terms of labs EKG, they're usually coming in for maybe a surgical consult. So those are all getting done anyway. If they were coming simply for a weight management consult, then I might do some labs. I may do an EKG, but not usually. It's not a standard process for that part. But in terms of if they are diabetic and they're on insulin, I usually try to stay away from that personally. It's not in my wheelhouse to feel comfortable trying to manage their insulin. So I do try to have them go back to their endocrinologist or primary care for that aspect. If they're on just an oral agent, I think I could probably manage it, but I usually try to reach out to their endocrinologist or PCP so they at least are on board with it, because I don't want to be trying to manage everything and not having them on board with it too. So it gets a little tricky. I think it depends on how many meds they're on and, really how brittle diabetic they are too.
Yeah. Thank you for that. I want to make one more last quick question, if that's okay. No, it's 5:59, you guys. Renee is probably like, oh my gosh, she's getting paid. I wanted to ask your input on, I try super, super hard to get patients involved in advocacy, and I refer them to the Obesity Action Coalition website all the time. Have you found a way to really get patients? Because that's where this push needs to come from too, right? Like they hear from us, they hear from surgeons, from physicians, from all the other providers, but they need to hear from patients to finally have some impetus to make some big changes. So have you found that your patients are excited about doing that?
Yes, there is no better advocate than your patient. They are better than any of us. And I will say there's a lot of us that are patients that make pretty good advocates too. So CMS, just released this week, the CMS proposal from the Biden administration is that CMS will start covering obesity management medications, GLP-1s. The proposal is for January of 2025. So we are very excited about this because we have put a lot of work nationally into talking to everyone that will listen about covering these drugs for Medicaid and Medicare. And it was just like, wham, bam, overnight. We're not going to pass TROA maybe this year, but we're going to give you this. Now, with the new administration coming in, I don't know what that means. Stay tuned. We're going to keep everyone updated. ASMBS, we signed on this week to a letter to the Biden administration, Trump administration through OCAN. And I mean, the beautiful thing about this is if the new administration does keep it and this proposal is made law, Medicaid is mandated to start covering these drugs usually within 60 days. So best case scenario, that means come March of 2025, you might be able to start prescribing Medicaid patients GLP-1s. So that, of course, is also state dependent. There's a lot of ifs with this. So I don't want everyone to run off the webinar and be like, Dr. Hilton said I can prescribe GLP-1s to Medicaid patients. There's still a lot of pieces to fall into place, but I truly believe that this has happened now because when we did our Hill Day for obesity awareness this past year, a group of us got to go into the White House. It was the highlight of my advocacy career. It will never be topped. And we met with Biden's Domestic Policy Council. And the two most important people in that room were two patients that we took in. And they told their stories. They told about how when they lost their private insurance and actually got on Medicare because of diseases that Medicare said they were disabled for, they covered treatment for those diseases, but not their obesity. It was incredibly powerful to listen to those patients testify. And I think that did it. I truly think that hearing those voices made an impact. I don't know, maybe I'm sappy. Maybe at this point, advocacy's turned me into a mushy person, but I think yes. The way you get your patients involved is you invite them. If you're going on a Hill Day, invite them to come. You all have that one patient that every time you see them, you're like, oh my gosh, you're the poster child. Let them be the poster child. Ask them to come do some work with you. I have several of them. They are my go-to people for when I need someone to go with me to Atlanta. So great question. Thank you, Christine.
Mm-hmm.
Wonderful. Well, again, thank all of you so much for your time tonight and your expertise. We very much appreciate it. Please feel free to share too with your colleagues that this has been recorded and will be available immediately after. And we hope to see you in real life at the next meeting.